Welcome to the Hot Topics podcast from NB Medical. Neal Tucker here, and this is a special edition of the podcast. Indeed, this is the start of a series of special editions interspersing our regular research Hot Topics podcast, during which we are going to interview influential people from the sphere of general practice. We'll be talking to people from the world of medical leadership, politics, media, and research, getting a glimpse into those worlds and the challenges within them. Just before we start, I've got to tell you about NB Medical's Black Friday offer. Yes, we have jumped on that bandwagon as well. So until the 2nd of December, we're offering £25 off an annual subscription to our NB Plus package. For just £320, you get to come on all of our live webinars throughout the year. You can watch everything back on demand. There's loads more resources in there as well. Plus, we will send you out a hard copy of one of the course books of your choice. So do check that out. We're going to start this series by talking to a hugely influential figure. So she is the primary care medical director for NHS England, the author of the Fuller Stocktake report, which has been hugely important in shaping the trajectory of general practice in England, working at the head of an organisation which, rightly or wrongly, many people working in primary care may consider as the bad guys, and at a particularly challenging time as many practices undertake the BMA's collective action. Well, enjoy the podcast, enjoy the interview, and I'll let you make up your own minds. So we're very lucky on the podcast today to be joined by Dr. Claire Fuller. So Claire is a GP, a professor, a former CEO of her local ICS, and then since last year, she has been the primary care medical director for NHS England. I believe at some point she's managed to fit in some time to come on a few Hot Topics courses over the years as well. So thank you so much for joining us today, Claire.
Thank you very much for inviting me, Neil. It's lovely to see you.
Maybe to start off with, Claire, could you tell the audience a little bit about yourself, your background in medicine, in general practice, the management side of things that you've been doing, and maybe your current role as well? That sounds like that's quite a lot to get going with already, isn't it?
yeah, that's right. Yeah, so who you are and where you come from. So I'm Claire Fuller. I'm a GP. I'm a third generation GP. So my grandfather was a GP in Peterborough in the war and spent his war delivering babies. So any 8-year-old men in Peterborough that are called Geoffrey are likely delivered by him and named after him. And then my aunt was a GP in Ely. And I have to say, from the age of wanting to do something, I only ever wanted to be a GP. So from about the age of 11, 12, it wasn't being a doctor. It was being a GP. And a lot of that I credit partly to my family history, but also as a child, I remember going to visit our family GP, Dr Brown, who I subsequently came to know in later years. But I can remember going to see her, and every time we went to see her, she would sit there, and she always had a cup of coffee and a chocolate biscuit, and she was wearing a short skirt and a jumper, and I just remember thinking, I can do that job. So it was a mix of family heritage, but also of having very, very strong role models, and always understanding that the GP being at the heart of people's families and people's lives, which I think is a great privilege and still do. So that's sort of why I'm a GP. I've had no aspirations to do anything other than being a GP, because actually that's what I've always enjoyed. So went straight from house jobs into GP training scheme, did the Epsom training scheme, and on the day of the interview met Nikki Hamilton, who became my subsequent probably best and longest friend, and we went through the GP training scheme together. Became a partner in the practice where I was a trainee, and thought that was me done. Thanks very much. I was a partner in my 20s and I was going to stay there forever. And then I actually ended up getting married and moving to Northumberland, and lived in Northumberland for about 7 years actually, where I had my 2 children. And actually moved from doing so in Surrey. When I was a partner in a fairly standard suburban practice, 7,000 list size at that time, with 4 partners. And that was pre-mobile phone, pre-computers. We did all our home visits, we did all our on-call. It was real proper general practice from back in the day. And then moved to Northumberland and started doing single-handed general practice, which again was extraordinary. So I was newly married, people have heard me say this story before, but became Dr Fuller from Wooler, because I thought that was really funny to be able to phone at the hospital and go, hello, it's Dr Fuller from Wooler, which is, it pleased me more than anybody else, of course. I worked in 2 practices, one in Felton and one in Wooler, and ended up doing proper single-handed practice in practices only had ever had male partners, and so saw some of the most astonishing pathology, actually, sort of in those early days of women that had not liked to bother the doctor and came in having tolerated extreme conditions. Used to have to go and do clinics in people's front rooms because it was so remote, and actually it took people so long to travel to sort of the main surgery. So used to sit on the sofa in this woman, I can't remember her name, front room while everybody waited in the kitchen, and they'd take it in turns to come in, and then it used to drop off the repeat prescriptions into the pub and into another one into a church porch where they did the thing. So, but it was proper continuity of care and proper being part of a community, which I loved. And then my husband died, and I moved back with the children back to Surrey, back to be near my family, and ended up going back to the practice where I'd been a partner. And at the time, my children were tiny. They were 3 and 4. And my younger one was diagnosed with autism and had quite challenging behaviour. And so actually I chose to work when H was at nursery or being looked after other people. So I ended up creating this really quite weird portfolio career. I did a bit of GP and A&E. So this was 20 odd years ago. And we had GPs at the front door of A&E trying to avoid admissions. It's just again, it's always this recurring theme of, the song never really changes, does it, in the NHS? But they would say, well, if the song doesn't change, it's just the singer, which I think is very true. So I did a bit of that. I became an appraiser because I could fit that in around school term times. I did a bit of looking after a community hospital with a fabulous woman that some people know called Eva Kalmus. And I have to say that was probably the best clinical medicine I've ever practiced in terms of making the right decisions for people to get them home that weren't necessarily things that on paper people would have done, but it was actually listening to what people wanted. And it's like, yeah, I know that, on paper that may not sound sensible, but we're going to make it work because that's what you want to do. And so that was clinically, that was a really happy time because you could see the impact it had on, and it was often end of life care for people and things. So that was hugely powerful. And then CCGs came along. So I'd had this weird sort of portfolio career that sort of fitted in around children's school hours. The then chair of that was the Surrey Downs CCG, Jonathan Richards, a man who's just retired now, so it tells you roughly his age then. And then he started setting up all the meetings in the evenings, and I couldn't go. And he was very clear he was only doing it for a year. And actually, what I realised that I was going to lose sources of income to support my family. And I very rapidly realised that the only way I could actually control when the meetings and things happened was actually to be in charge. So I became the chair, and we, funnily enough, had all our meetings in the daytime. So it was never a grand plan to lead but actually it was the thing that worked for me to support my family. And then actually I found I could do it, and I enjoyed it, and went quite quickly from being the CCG chair to being the CCG accountable officer for a small bit of Surrey. And then when STPs came in, I became the clinical lead for the STP, and then started being the exec lead for the ICS. And then in time, the ICS and the CCGs had then merged and came together. And during COVID, I then became the accountable officer for the CCGs, and then got appointed as the chief exec for the ICS. It was this, I've always had this thing of sort of starting clinical, then going executive, starting clinical, then going executive. It's my comfort zone. And then was 2022, so I was the chief exec at Surrey. And then Amanda Pritchard phoned somewhat unexpectedly and said, we're going to do this review looking at primary care and systems, because ICSs were just forming then. Would you do it? And I just went, yeah, of course I will, because you do. And I had no idea really what would happen. And it was 6 months of me falling back in love with general practice, because I think I'd very much had an executive career up until that time and saw myself as an executive rather than, I will always be a GP, but it was a reconnection for me with back where I'd started, which was incredibly powerful, because of that, when this job became available, I realised actually that was the next thing that I needed to do and wanted to do.
So there may be people out there who are not very familiar with that big report, the Fuller Stocktake report. I'm sure lots of people have heard about it, but maybe they don't understand the detail of it. It's easy not to be up to speed with even big, important documents in general practice when you're just trying to get through the day. So maybe can you give people a little bit of an idea about what that was about? What were you being asked to examine, and then how did you go about it?
Yeah, so it was a report written for the chief execs of the ICSs at that time, which is important because there's the target audience. So I started off by meeting with each one of them individually and going, so what are you proud of? What do you need help of from primary care point of view? And a number of themes rapidly came through. And from that, we developed a number of work streams. So, it's all the things that people would expect, estates and data and digital and workforce and leadership, all the stuff that we all know are a real problem. But one of the bits that was quite surprising was actually then the examples of best practice from around the country of where people were managing to make it work and were managing to support primary care in a different way. And from that, we came up with the vision around neighbourhood health, which actually is subsequently carrying on in the integrated neighbourhood teams. But the report had 15 recommendations, and half of them were for NHS England and the Department of Health, and half of them were for ICBs to implement. The things that people said weren't working, and this were people as well as professionals, and there's no surprise to anybody, is that we've overvalued access and have lost continuity. We talked about all aspects of primary care, but actually general practice in particular is a very hard place to work because people are not able to do the job they feel they were trained for and the job that we all love. So the model of care, the integrated neighbourhood team, was actually a way that has been evolving around the country for actually to allow general practice to get back and do what general practice does well, which is looking after people in their community in a holistic way. So there's three arms to the neighbourhood team. One is how you do integrated urgent care, one is how you look after your complex patients, and the third one is about prevention and how you work with your communities to actually properly drive down those health inequalities and make sure people access care that need it. But I think the bit that's probably been most misrepresented has been the on-the-day piece.
There has been a lot in the medical press about
exactly.
that. Well, it'd be very interesting to hear your take on it, actually. I can see the dilemma here, because if you're stripping out on-the-day access for patients, well, this is a perception of what's going to be happening. If you strip that out, then you're losing that continuity that's really important in general practice. So what actually is the idea here then?
Yeah. So in the ideal world, we would go back to where I was in Wooler or where I was in Banstead, where you have your list and you do everything for everybody. But because of all the reasons that we know, the rising complexity, the rising demand, the fact that actually we're able to do so many much more complex things, there are not enough of us to do everything in the way that we would want to do. But also, the thing I've noticed is the things people are asking for appointments for are not things they would have asked for 10, 20 years ago. So there is a whole raft of demand of people that are seeking reassurance about things that they probably would have dealt with in another way. And so what we talk about in terms of taking out some of the on-the-day demand is actually for people that are otherwise fit and well, who have got low acuity problems, to actually have them seen somewhere else. So that then actually those people that have either got, and then that then frees up our time to actually see more complex things. So it isn't taking out all of the on-the-day demand, it's taking out the low acuity for low complex people. So it would be, my children will forgive me, it would be my son running out of his Fusidin for his eczema again, and needing a repeat prescription. Mind you might say actually if he saw the same person, they might tell him not to lose his Fusidin, and then it wouldn't be an issue. But it isn't for people like my father with his Parkinson's and his renal failure and his heart failure and the rest of it. You would never. You want to free up so that he can see somebody that knows him really, really quickly, because at the moment he waits to see somebody that knows him. By which time we've got a blue light ambulance outside and we're rushing off to the Royal Surrey again.
It's true that your duty doctor lists are often extremely long, and it's easy to miss some of the more important issues in there, or it takes a long time to get to them, which is not ideal.
And we've made the haystack just bigger. And actually what we need to do is shrink that haystack so we can find the stuff that we need to do. And there's some things that in the report we talked about risk stratifying the population. So it's the classic red, amber, green type stuff. So so if you're red or if you're amber, you would no way say go to pharmacy first or go anywhere else or do anything else, because actually we know that if we prioritise you to be seen quickly and by somebody that knows you, it's going to shorten your illness. It's going to the whole thing's just going to be more efficient, isn't it? And we'll deal with it in one conversation rather than 5. And you see the stuff of people, the wrong people that are sent to other bits of the system. They bounce, don't they? And they've been sent to the pharmacist who's sent them somewhere else, who's sent them somewhere else, and they've gone there. And then by the time they come and see us, they're at screaming point. And then we'll see them and we'll go, yep, you need this. And you can see then why they go, well, I just want to see my GP, because we will fix it and we will sort it out. So we've got to make sure that it's the right people that are diverted into the on-the-day bit, or into the surge hubs, whatever you want to call them, or are seen by Pharmacy First, or are seen by the minor eye clinics, or diverted to online resource.
That's very interesting, because that's a different side that you don't hear in the
Indeed.
GP press very
Indeed.
often.
Indeed.
And makes a lot of sense. I guess the challenge there is going to be educating patients and having a system that makes sure that everyone understands who needs to be going where, when.
We see that, and that's lots of people are doing this already really successfully. A lot of people have done the John Hopkins, Frimley, I think, sort of led the charge with this. So, and we live in the Frimley system, and so on my NHS app, I'm a green. They've got green, and my dad's red, and my mum's amber, actually. And actually, the conversation relates to which one of those clinical groups you fall into. Then other people have actually put in place other sort of triage methodology, where actually if you're green and then you come in, so if I phone up as green with a sore throat, so something where I know I would need an intervention that was transactional and one-off, that I would get sent away. But if I was phoning up with recurrent abdominal pain, I wouldn't be expected to be sent off to a hub. I would be expected to see somebody, have my investigations, and go back to that same person. And at the moment, we haven't got capacity to prioritise the episodic continuity as well as the holistic continuity. Because even as a green patient, I'll have times when I want to see the same person. It's all the classic things we know, isn't it? It's investigations of infertility. That's a lot of conversations that are really deeply personal, that need the same person coordinating them. That's not a send somebody to the hub, and that's not a green acuity presenting problem. That's a one where you would want, and it's also something you'd be prepared to wait to make sure you say it's all the same person, rather than having to be seen on that day. We deal with this day in, day out as GPs, but I think to the rest of the service, they really don't understand the complexity of the way people present, because when people present everywhere else in the service, we've already packaged them up. So it's like, and somebody brilliantly described that, general practice is the jungle with everybody roaming loose and all the rest of it. But actually hospitals are like a zoo, because actually you put people into a pathway, you put them into a cardiology pathway. But actually when they come to us, they might be short of breath, abdominal pain, and we're sorting out where to send them. And that's the bit, unless you've lived and breathed it, they don't understand.
From the report, there's a few concepts that come out of it that would shape general practice over the next few years. How do you go about generating that change in a system that's so vast?
Yeah. So I'm fairly simplistic in my change methodology, to be honest with you. The only way change really happens is through clinical leadership, which is partly one of the reasons why I took this job rather than staying in a managerial job. And it's about doctors working in different ways. And I think one of the bits that really came through from the report was this real schism that was developing between hospital doctors and GPs. And actually also Wes's Secretary of State's speech on Friday announcing red tape challenge that Stella Vig, who's my counterpart in Secretary of Care, are going to be leading, is actually working at how we can just make that easier for people to actually make best, so that the time that we spend with people is about patient care rather than about either clinical admin or non-clinical admin tasks. So I believe, and the best examples that I've seen going around the country, is actually that when you create the right environment for clinicians to look after people, then actually they form themselves and work out how to do it, and actually naturally work out what are the bits that are getting in the way. And when you get people sitting in a room together, they do get on with it. So it's the identify your leaders and protect them and give them time, show some examples, show people data, and then start to compare and show them how other people are doing. And actually then the change happens. And although, I mean, I've visited, I think, 37 out of the 42 systems now, and which is fabulous. It is, just going around and meeting so many people, and they've all shown me what they're doing and what their version of the neighbourhood team is. And yes, they're all slightly different, but the concept is the same. They're bringing people together to look after a population. And in some places, they might be talking about the homeless population. In other places, it might be older people. But nonetheless, the concept is it's bringing together community, mental health, secondary care, voluntary sector, social care, all into one room to actually have a conversation and work out collectively how to do things. So I think the thing that is different with this is that it is bottom up rather than top down. In terms of it's actually just creating the right environment, allowing people to get on with it. But what you're now seeing with the new government and with the Labour 3 shifts and with the manifesto promises is actually now starting to get a top-down shift into people working together, not in a hospital. So and we're calling they're calling it the neighbourhood health service, but I think neighbourhood's not necessarily always a helpful word because it means 12 things doesn't define people. My neighbourhood is my road versus actually the whole borough of Southwark, might be what we're talking about. So yeah, but it has to make sense locally.
I see that NHS England, I think maybe was it just last week, has announced about these the 22 PCNs piloting.
Yeah.
Is that something that's directly come out of the Stocktake report that's kind of trying to drive that change?
They're all building blocks. So, the primary care access recovery plan, which was talking about making sure we've got functioning telephony in every practice and pharmacy first, they're all building blocks that go actually to sort of level the playing field so that people can actually start to do change because they're not worrying about having a phone line that doesn't work. We've got real basic stuff that we need to do. The PCN pilots, so they're locally led. And it's a joint initiative between the ICBs and NHS England, which, again, hasn't happened before. And they're really, I think it's going to be really interesting because actually we haven't got a predetermined outcome of where it's going to go. The starting hypothesis is that there is more demand than capacity in general practice. Yeah. And actually, if you ask all GPs, the answer at the moment you come with, what is that gap? And you'll get somewhere between 10 and 50%. But nobody can be more precise. And that seems to be the range. Nobody says it's less than. Everybody agrees there's a gap. Yeah. And we all say, the most optimistic will say it's about 10%. And, we need twice, half, 50% again. And what the pilot's doing is to try and work out what that gap is. So it's a hard work data collecting exercise. Actually, they're in their first audit week at the moment, the 22 PCNs. And what we've asked in each of the PCNs is for them to record morning and afternoon what everybody in the PCN is doing. So for many people, that's about 150 plus people. And it's what percentage of your time is on patient facing, what on clinical admin, what's the makeup of the team that you've got. And then we'll start to compare and look at how people are doing. And then we've asked people to prioritise a number of areas, and it's proper old-fashioned improvement work. Look at it and change something and see what happens and run it as a sprint. And then we'll rerun the audit week and have a look and see. And we'll look at the, who's managing their demand. So everybody wants to talk about primary secondary care interface. The other sort of things they're talking about is how you can better do continuity of care. Some people still want to work on access, vaccines and screening. It's sort of that real population health management and the risk stratification. So there are lots of different areas that people want to work on. And again, it's their choice. But this is a data collecting exercise and an improvement programme to see what we're going to learn. And it will run for 18 months to 2 years, and then we'll see where we go. So I think it's really exciting because we don't know what it's going to show. But we start with that there is not enough capacity for the demand.
It's so interesting talking to you because you tend to read about the cynical side of the takes on this, that this is an exercise on collecting loads of data for general practice to see what they need to do to kind of control it in some way and how to manipulate general practice into the will of NHS England. Yeah. But actually it sounds much more something that appeals to me, which is
exactly.
It's essentially you're doing a trial.
And it's about the data and it's about and it's quality improvement.
I know that after the Stocktake report, like all of the CEOs, if that's the right phrase, of the ICSs around the country signed up to the report. They agreed with the recommendations within the report. it might be reasonable to say that those leaders that signed up to it are people that are quite into management and leadership and that kind of thing.
Yeah.
So have you experienced any pushback from grassroots GPs, like the people who are just kind of working on the ground, trying to get through the day, that kind of thing? I mean, did you get a feel for how people have responded to the ideas?
Well, I think your first comment about actually most people don't even know probably the report was written or it happened. Let's face it, because most people are just getting on and doing their job and just trying to get. So I'm under no illusion. Most people don't know it happened, don't know anything, and that's absolutely fine. And I think it's my job to try and make it easier for people to just get on and do their job. I think there's been a degree of pushback from people that didn't understand or read the headline version of what the report was. And a bit like you, so no, I get that. I can see what you're trying to do there. So I think there was pushback there, but that's actually been that's deliberately sort of why I've gone around all the country and met people. I'm going to share an analogy. So if you get two GPs in a room cooking Christmas dinner, and we appear to be arguing about whether to put wine in the gravy or not, it's not that we're arguing about cooking Christmas dinner. It's not that we're arguing about the fact that we need gravy on our dinner. We're just arguing about what order we might put the ingredients in. And woe betide anybody else from outside the family that then tries to have an opinion on what should go into the gravy. And I think there's an element of that. So we're all saying that general practice is a fabulous job. We're all saying the funding is not, Darcy report, the funding is not where it should be, and we would like more recognition in the rest of the system. We would like more emphasis on the non-hospital environment, and we might have slight nuances about who and what that might look like. But actually, we're not a million. It's 80% of the time. I think we all agree on what we're saying.
We're coming to a close soon, I think, Claire. But maybe a couple more questions for you if we've got time. So, firstly, we've had a change in government recently. Do you think that that's going to make it easier or harder to implement any of the recommendations from your report? And, do we feel like that's going to be a positive for general practice? Maybe that's two different questions.
Two different questions, definitely. So the implementation of the report, I think if you actually look at what the recommendations were, the systems are getting on with it. I think there's just that it's not universal, and it's patchy around the country. So I think we're getting on with that. I think the Labour three big shifts, from hospital to community, from treatment to prevention, and from analogue to digital, are all very much in line with the things in there. And the Manifesto Commission commitment again to return of the family doctor, they're all things that are actually in line with the report. So I think that's all very positive, and we're already seeing this commitment to neighbourhood health. And actually, that this real focus on non-hospital providers and non-hospital medicine and what that might look like. So I think there is attention. I think there is impatience. We heard Secretary of State's speech at the RCGP on Friday, again, making that commitment. He's the first Secretary of State that's been to the RC. They have a slot every year. First one in 7 years, I think, there's been. Made that commitment to, GPs being on the specialist register, which I think feels important in terms of recognition. And again, making that commitment that although there's a long way to go, it's an understanding of it's taken a long time for general practice to be as undervalued as it has been, and there is a commitment to change that. So I know I am pathologically optimistic, but I am hopeful.
Thank you so much, Claire. I think sometimes there's this perception that NHS England is the bad guys.
Yeah.
I think speaking to you for half an hour has definitely made me reevaluate that quite significantly. So it's been eye-opening.
Thank you, Neil.
Maybe hopefully we can do this again sometime.
That would be lovely.
Well, I hope you enjoyed that interview. We'll be back with a regular podcast in the next couple of weeks. Remember, you can always get in touch. Email hottopics@nbmedical.com. We're on Facebook and X as well. Don't forget to check out that Black Friday offer running until the 2nd of December. And in the meantime, look after yourself. We'll see you soon. Bye-bye.